So I started my career at the Mayo Clinic. I did my training there, fellowship, and then was appointed assistant professor in the Department of Neurology there. Loved that experience. Had an opportunity to do some research of my interest. And then I left around 2000 and I joined Boston Scientific. I was based out of the Maple Grove office here in Minnesota. And my role there was part of the business development team. At this time, Boston was experiencing tremendous growth and innovation, primarily in the drug-eluting stents. And they were looking to expand their footprint outside of interventional cardiology. So again, I had the good fortune to be a part of a team that was looking at emerging technologies, really disruptive stuff outside of the traditional endovascular technologies that they had, already developed. So that was really my first foray into industry. Before, I'd always been in kind of academic medical environments. That gave me an opportunity to continue to scratch that curious itch that I always had. As a researcher, you have that. But it also exposed me to how products are made, how they are developed through the various rigors of the FDA, how you think about marketing them, what is your go-to-market plan, how do you build a sales channel? All of those discrete steps that you need to think about and plan and execute on. I had never done, was exposed to it, and was tremendously excited about it. The energy, of taking something from the back of a napkin and developing it and going through iterations and the successes and the failures and the fits and the starts. That part of product development was tremendously exciting to me. So while I was not involved in any of those directly, I had a chance to see how that was played out by the fact of evaluating and being involved in some of these companies that we were interested in to eventually invest or acquire. And then I think that was the entrepreneurial match that was lit in me. And then my first technology that I really started, or company that I started, was OrthoCor. So on independent research, I came across a whole host of sciences on magnetic fields. And what they do is they perturb, either favorably or unfavorably, they perturb the cell membrane. All of us have cells and all of us have membranes that encapsulate the cells. And they're different depending on the type of tissue, whether it's bone or blood or dermis or brain, and many others. So from a very, I would say, general statement, and there are exceptions to any general statements, and there are exceptions about what I'm about to share, but in a general statement, if you can influence the cell membranes, and the cell membranes not only protect the cells, but they can elicit a signal. In the biochemistry world, this is called second messengers. If you can influence these second messengers, you can tell the cell to do something, to make a certain protein, to act in a certain way. You can also, by providing magnetic fields, increase blood flow. And I appreciate it in many of these areas where you have a disease condition. The problem might be improved or hindered by blood flow, right? In some cases, you don't want blood flow in the event that you have a bleeding, such as a hemorrhagic stroke. You don't want to bring more blood flow there, right? But in areas where you don't have good cell turnover, you want to bring more blood flow there. So one of the areas I was intrigued at was cartilage. And why is it that cartilage or any type of connective tissue, so cartilage in your joints, tendons that are involved in your joints as well, and ligaments, right? So those three kind of big buckets, they all, while they may look different and they do different things, one of the common themes they have is they don't have a lot of blood flow. And there's not a lot of turnover in the cellular function, right? That's good because it provides stability. It's bad because when you have an injury, whether it's your cartilage through degradation, whether it's your tendon and ligaments through a tear, right? Let's say it's overuse injury. In any of those cases, if you have an injury, because the environment that they've been programmed to, they don't have a lot of blood flow. It's very difficult for the body to heal itself. I would submit to you the body's probably the best healer, the best source of repairing itself. So I go back to the ability of magnetic fields that you can't feel, right? You appreciate some component of it, but it's not as if your temperature rises or you have a sensation when a magnetic field, at least a therapeutic magnetic field, is applied to you. But what if you could put a magnetic field to bring in blood flow to an area that doesn't have blood flow? And what if this could be done to help repair and remodel that tissue? So I thought about cartilage. And the science of magnetic field, specifically pulsed magnetic field, where it's not constant, you know, it's an on-off, and the amplitude and frequency can be manipulated. But what if that could be put to cartilage to essentially shock the system? And I'm using that word broadly, but to stimulate that environment to do something different. And that something different is bring more blood flow, and for the cells that deposit cartilage to ramp up, to put more cartilage, to start producing more cartilage, to repair an area that had been degraded, right? So that was the broad thinking. What if you could do that? So there is science out there on magnetic fields, published science, peer-reviewed, that it can have this effect depending on the target tissue. It can bring more blood flow, it can increase the cells that you're influencing to put more proteins that they're already programmed to do. But then how do you put it into something that is usable? At that time, things have changed now, but you know, going back many years when this was developed, there are portable handheld devices that give the magnetic field. But in the case that we initially thought of, the initial use case was, for example, arthritis in the knees. And the arthritis in the knees, there are many contributors. One of the earlier contributors is this degradation of cartilage, right? Where you don't have a nice surface on both aspects at the joint of the knee, and that contributes to the pain. So what if you could wear a wearable brace, and that brace obviously gives you some comfort to the knee, and what if you could deliver some device that you could put in, that you can control as a person, and you would put in or slide in onto that brace, and it delivered this pulsed electromagnetic field stimulation. And you could wear it. And then you could wear it for however long you want to wear it. So you have the option, you have the control, right? That was the initial approach of this. And then we added, well, if someone's going to wear it, you'd want to see if you can add something else that could be an additional added benefit. And that additional added benefit is heat, right? Heat per se is not going to have a sustainable effect in terms of the remodeling, right? So we knew that that wasn't going to be clinically meaningful, but it would be appreciated by the patient as being that warming effect would be positive, right? For them to encourage to continue to wear the brace, and then you have the electromagnetic field stimulation. All of those things were really the initial components of this. How do you have a brace that somebody would wear comfortably? How would you have heat that would give kind of a rewarding effect to it? But then how would you be able to deliver in a portable way and in an inexpensive way this pulsed electromagnetic field stimulation? That was really the initial building blocks of the technology that became the OrthoCor brand of products. That's the great thing. So it actually started with, you know, I always put it in this phrase, it was a dopey idea in my brain. And it really was, at that point, unstructured, right? You had these different ideas of how you could do things. There were some crude sketches. Back then, I had the ability to work with a group of engineers. These are graduate level engineers, graduate level engineering students at the University of Minnesota. And this was one of the projects. So that was the fun part of this, is to get some very bright people who understood electrical engineering and mechanical engineering and medical devices. So you bring the interest of those kind of areas, right? Because you knew that this is an electrical engineering problem, it's a mechanical engineering problem, and then you needed to make it so that it fulfills some of the requirements of a medical device. So the engineers were pulled together. I was their sponsor, and we were developing this, coming up with some of the crude embodiments. From that, we were able to reduce it into a patent. And so that patent was the first part of this. One of the engineers went on to become an employee of the company. So that was one of the outputs, that this was of an interest enough to him. We were certainly very happy to have him join. So as the idea was forming, the company was forming, and then this was the convergence where this specific individual said, you know, I'd like to be involved in this in a more significant way. So that individual, Kinjo Sham is his name, he was also instrumental in helping design some of the specific embodiments. Like, what did the brace look like? What did the circuitry look like? What was the actual pulsed electromagnetic field? So between him and I, we figured out what those parameters were, right? What do we think would really work in terms of stimulating the cells? Because in many ways, it's a specific amount of pulsed electromagnetic frequency, right? That's the F. That frequency is also important. Is what's the lock and key? What's the right frequency to stimulate these cells? Because all cells are different, and they'll be stimulated at different frequencies, right? So in many ways, it was research, and I would say trial and error, you know, when we're doing stuff at the cellular level. So he was a big part of this. And then obviously what you need to get this going is investors. So as we were developing this, I was involved in going out and raising capital for this. And then you start thinking about what I said in the beginning. What is your regulatory pathway? And what is, you know, is this something that you need to go through the FDA or not? And a lot of that depends on the claims. What are you going to claim this device does for people? So we had consultants to come in to help develop that. And that's, to me, that's probably the most exciting part of this. Because whatever idea you have, you're starting to refine it with all of these inputs to kind of hopefully lay it up for the most successful path. How do we consolidate the heat and the electromagnetic therapy in one pod? And we were calling it a pod at that time. That was tricky to kind of bring those two therapies. And how are we going to turn on the electromagnetic therapy, right? Because you want it to have an effect as you kind of slid it into the brace. So that engineering challenge of turning it on and combining two different, if you will, sensory functions, a magnetic field and a heat, kind of coalescing those two was not an easy engineering challenge, right? And the other one that I think all medical device companies are challenged with is cost of goods, right? Because you need to make this and design it at a price point that you can still afford to manufacture it at scale, so you could sell it at a competitive price. You know, the trick is, and we learned this at OrthoCor, the trick is not how do you design it for one use. How do you design it that you can manufacture tens and thousands? So a lot of times, what medical device engineers realize is you have to incorporate what's called design for manufacturability early on. So when you're designing something, you're thinking about its performance, its tolerance, what is it intended to do? And you're thinking about a product. We came across early on, well, we're not going to make one product. We want to manufacture tens and thousands, right? So how do you implement all the regimens, which is called design for manufacturability, so that your costs are low and you could have reliable, reproducible manufacturing processes? That was not easy to do. But you know, I give tremendous credit to the engineering team, you know, led by Kinjo, that he was able to unpack a lot of those problems. So at the cellular level, you think about the pulsed field. The pulse field, as I said, is going to perturb the membrane. And in this case, we're looking at the membrane of the cells that lays down the cartilage, excuse me, not cartilage. it's going to lay down the cartilage. Those cells then, as you provide the right frequency, remember there's a lock and key, if you provide the right frequency, the idea is that you're going to then stimulate those cells to lay down the proteins that they're designed to make. So for example, the cells that are in the joint of your knee that lay down cartilage, they're going to make the collagen that is the constituency of what makes up cartilage. They're not going to make the protein that resembles the hair follicle, right? So these cells are already pre-programmed. They know what their job is. So if you can stimulate them to put down more protein, that's a good thing. And then on top of it, if you can bring more blood flow to the area, they're giving that nutritive supply, that nutritive signal to do more of what they're being asked to do. So that's the thinking. The challenge is it's very difficult to kind of measure this, you know, from how thick was your cartilage before and after, because it's a very thin, if you will, area of cartilage. It's difficult to measure that. So you're left with attempting to measure it functionally. Does the person feel better, right? Is the pain relief appreciated? Is the person's quality of life improved? And you have to ask them to take some questionnaires to respond to that. Is their range of motion improved, right? Are they able to move it, the joint, in this case the knee, at a different level where they couldn't have done it before? So that's where clinical research comes in. You have to put the brace into the hands of people that are suffering, in this case with arthritis of the knee. You kind of get a baseline of what you believe is their baseline pain, quality of life, range of motion. Then you put the brace on, and then you continue to measure them over a period of time. All right? And then if you want the real rigor, because you always worry about placebo, right? Do they just want to get better? So the right way to approach that would be to do a placebo, where you put the brace on, but you don't turn on the gas, right? You don't put anything that has electromagnetic field stimulation, right? And that's a way to think about really the focused, specific impact of whatever therapy you're trying to deliver. One of the drivers of this is we knew people can tolerate a fair amount of pain. You know, as, let's just pick arthritis of the knee. As you have arthritis of the knee, it typically comes on with overuse or some form of trauma, right, over a period of time. And so arthritis doesn't come at you, you know, like a thief in the night. It's gradual, right? And your pain and the loss of function is a very gradual onset. And then you compensate. We as humans are very good at compensating with things, and you just kind of live with it. And then it reaches a point where it really starts to impact things that you enjoy doing. You can't exercise as much. It hurts a little bit more to get up out of a chair. If it hurts you now to pick up your grandchild than it did a year ago, right? Those are things that are meaningful, all right? Then your next option is either some medical treatment, an intervention, and then eventually you may be a candidate for surgery. And that's in the form of some type of knee replacement, all right? So those are your kind of, as you see the arc of this, that's how you're gonna be moving down. What if you could have a brace that allows you to continue your daily activities, and it gives this therapy that stimulates the production of cartilage? And what if it could slow down that path? So we weren't, at least I wasn't thinking that this would eliminate the need for you to have surgery, right? Because you're on a path. For whatever reason, your knee has arthritis. So you're on a path of decline. Is there a way that you could slow that down or stabilize it for a while? So that, again, I'm giving this as an illustration, not to be specific, but instead of having a knee replacement 5 or 7 years down the road, maybe it's 10 years down the road or so, right? It buys you a little bit extra time. And oh, by the way, during that time, you still enjoy a relatively pain-free lifestyle, and a lifestyle which has a good quality of life. That was the thinking, right? That you essentially allow somebody to buy some time.